Today we will discuss about the eye banking. The keratoplasty term was first given by Franz Resinger in 1824, and he suggested to replace the human corneas with the animal corneas. In 1837, another scientist, Samuel L. Bigger, did an PKP on animals on gazelle in Egypt. Gazelle is kind of a reptile species. In 1905, Edward Zerm, he did the first human transplantation on the patient named Golgi, and the patient was transplanted with both eyes. And who was the first donor? The donor was Carl Breyer. Dr. Jim uh, took took the graft from an 11-year-old who had a bicycle accident and transplanted two 5 grafts on the eyes of Golgi. The PKP has a 73% graft survival rate. Evolution of keratoplasty, it started with interior lamellar class keratoplasty and DALK, and it shifted to DSAEK, Descemet's stripping interior endothelial keratoplasty, and now it has shifted to DMEK, Descemet's membrane endothelial keratoplasty. Who was the first corneal donor? Already discussed. He was Carl Brauer, who had a bicycle accident, and Dr. Edward Jim transplanted his cornea to the patient named Golga. What is the history of eye bank? In 1931, Vladimir Filatov of Russia did the first cadaveric corneal transplant and preserved this tissue for 24 hours. This was the first time the corneal tissue was preserved for at least 24 hours. In 1937, the first US cornea transplant was done by Patton In 1944, Patton established the first eye bank in the US in the New York City, and he took the first donor was a prisoner from the New York. And the first eye bank established in USA was to systematically plan to obtain, preserve, and redistribute the eye tissue. In 1955, the American Academy of Ophthalmology and Optometry Committee was established on eye banks. And in 1961, the first eye bank association in the world came in the name EBAA, that is the Eye Bank Association of America, which consisted of surgeons as well as the lay people. And this Eye Bank Association of America established the medical standards and accreditation procedures for the eye banks. Next, we will come to what is the process from donor to the transplantation, and this total process takes almost 14 days in total. The first is the death notification. All hospital deaths 24 into 7 have to be notified, and these are the main source of referrals or the families. Then we do the donor screening. We collect the medical info, past medical history, past surgical history, and his family history from the kin. Then there is authorization and risk assessment interview, that is the DRAI, that is the donor registry. People do the assessment interview and take the next of the kin consent. Then we recover the tissue. Then there is tissue recovery, and we take the consent during the tissue recovery for both transplant and research. And the tissue has to be recovered within 12 to 18 hours of the post-mortem after the donor physical assessment. The tissue recovery can be in two forms. It can be either full eyeball enucleation, or second can be corneal scleral rim. We can take only the corneal scleral rim. The preservation medias which can be used are the Optisol GS, which is a cold storage media, and the cornea button can be stored in it for around 14 days. After the tissue recovery, the infectious disease testing is done for hepatitis B surface antigen, hepatitis C virus, for the hepatitis B core antigen, HIV, and the syphilis (RPR). After this, the tissue evaluation is done and the endothelial cell count is done. and the tissues having the endothelial cell count more than 2000 cells per millimeter square are taken for the transplant. These tissues are then sent for tissue storage. After donor eligibility determination and ruling out any transmissible conditions such as tumors or infections, the tissue is sent for processing for DSEC or for DMAC. For DSEC, when the tissue is less than 100 micron thickness with the stamp, and for DMAC, the stamp is put and then the tissue is put in the injector. The final evaluation is done and tissue is distributed to the hospital for utilization and follow-ups. There was one system called OARRS. This is the full form is Online Adverse Reaction Reporting System, and this system is online since 2004. Early regraft will be needed for the endothelial keratoplasty tissue did not clear between the early 8 weeks. Then we need an early regraft. There is an increased fungal infection after endothelial keratoplasty, and to decrease this incidence, we have to use 5% povidone solution at least 2 times before surgery. There was a donor-related melanoma after keratolimbal allograft, and therefore the melanoma is considered as a contraindication for transplantation now. Contraindication for transplantation now. Next we come to ACE2. ACE2 receptors, where are they found? The ACE2 receptors are the key cell surface receptors for binding the viral spike protein of SARS-CoV-2. The expression is positive in conjunctiva, limbus, cornea, choroid, vascular endothelium, and nerves, and the overexpression is seen in diseased epithelial cells. If there is an inflammation, then also there is more expression of ACE2 receptors. But the ACE2 receptors are there less in ocular surface than in the lung tissue, and no coronavirus transmission was found through the ocular tissue. Descemet stripping only is not a transplant and hence is not covered under the corneal transplantation procedures. Surgical management of the corneal disease from anterior to the posterior should be done, and if it fails, then we have to go for PKP.